Hello, Noel.
Ranjit?
I've got a question for you.
Yeah, shoot.
Um, we often get parents who bring their children into A&E with head injury and with vomiting as a sole complaint. How many episodes of vomiting is significant for us to consider CT scanning?
Right, so nice guidance says if you have 3 or more discrete vomiting, that is a risk factor. But if that's the only risk factor the child is presenting with, then that is not an indication for a CT scan. We do need something more with it, either a GCS being getting dropped, or the child is abnormally drowsy, or there's some high mechanism, or something has to go with it for us to think about getting a scan done within an hour. But as you said rightfully, we see quite a lot of kids coming into ED only as a vomiting as the complication post a head injury. So if that's the case, then we do have to keep them minimum 4 hours of observation from the time of injury. But in practicality, we keep them for 4 hours from the time they enter ED. So that's normally we keep as a window period to look for any further vomiting or any drop in GCS or any abnormal drowsiness. So these are the 3 other very specific things you're observing for, because you
During
need to
that
know
observation period.
exactly, because
Okay.
you need to know why you're keeping the child for 4 hours and what are you looking for.
Yeah.
So that's what nice guidance want us to look for. And if any of those present, even another episode of vomiting, then the child needs to get a CT head done within an hour.
You mentioned about vomiting episodes being discrete. How do you define this? Like, what do you mean by discrete episode of vomiting?
Unfortunately, we do not have a definition for it. Even nice guidance doesn't give us a definition what this discrete vomiting is. So it is up to our clinical judgment of what we're going to perceive as a 3 or more discrete vomiting. So vomiting right after a head injury, or is it vomiting after an hour or 2 hours? We just don't know what the time period is. And 3 episodes, are they back to back? Or are there any time between them, like 10, 20 minutes maybe? It's just not defined clearly. So again, clinical judgment plays in it. But what we do want to tell is that no longer we think it's only the projectile vomiting. So whether it's projectile vomiting or not, that is irrelevant. So I'm going to say clinical judgment.
What about the original study, the Chalice study that was used to formulate the pediatric head injury guidance? Do they actually explain what discrete vomiting means?
Unfortunately, the authors of Charlie study haven't given us a very specific definition for it. So the nice guidance, which was adapted from the Chalice study for the pediatric head injury, has followed suit with no clear definition.
All right.
Okay, Ranjit, I have a question for you. So we get quite a lot of elderly patients being brought into ED with the history of a head injury. Right, so then we look at their medical history and their drug history, and then we find out they are on an oral anticoagulant for whatever reason. For example, the most common reason being in atrial fibrillation. So we see the age, we see they are on an oral anticoagulant, and then we have a history of head injury. Instead of them being asymptomatic or no other symptom associated with the head injury apart from the said criteria, we get a CT scan done for them, right?
Yeah.
So what do you think regarding this presentation?
So, as per the 2023 NICE guidance on head injury, if a person comes to us with a head injury but they're asymptomatic, meaning there's no amnesia, no LOC, and they're just on an anticoagulant like warfarin, DOAC, or on antiplatelets, apart from aspirin monotherapy, the guidance recommends, actually they word it as consider doing a CT scan within 8 hours from the time of injury, or within the hour if they present to us more than 8 hours. When looking at the explanation given by the committee as what did they mean by consider doing a CT scan rather than doing a CT scan, this is where it gets quite vague.
Right.
Basically, they've left this decision with the clinician who's looking after the person. It's at our own discretion. Either we can choose to admit the patient for further observation for 8 hours side by side, we need to risk assess. We need to look at things like who lives at home with this person, are they safe to be discharged, what was the cause of the fall, what's the risk of future falls in this person, and for other trauma in the same person that would warrant a separate CT scan. If the patient comes under low risk, we can have a shared decision with the patient. We tell them that you come under low risk, you may not need a CT scan, and if they are in agreement, we can do without a CT scan.
But if you look at the secondary CT criteria for head injury as per the NICE guidance, it says that if patient has an LOC or amnesia and have any one of the risk factors, and one of them is having a bleeding disorder or being on an anticoagulant. So in an absence of LOC or amnesia, and only just because the patient is on an anticoagulant, would that suffice enough for us to say this patient would need a CT scan?
That's an interesting observation. So the way the NICE guidance, the algorithm flows, like you said, if a person has amnesia or LOC, it takes us through risk factors, one of which being bleeding clotting disorders, and they include liver failure, hemophilia, along with someone being on an agent like DOAC, warfarin, so on. And if they are, then we have to do a CT scan within 8 hours of the injury. Okay. On the other hand, if there's no amnesia or LOC and we go down the other arm of the algorithm, it just mentions about an agent. It doesn't talk about hemophilia, liver disorder anymore, which is a bit counterintuitive. That's what I would think. I had a look into the committee's explanation, but there was no good reason that I could understand, like to explain this question. If anyone out there is watching this video has an answer as to why this is, feel free to drop it in the comments. It's good for our learning as well.
True.
So I've got another question for you. It's kind of a scenario. So there's an 86-year-old patient who's brought by ambulance. They are from a care home. They've got a DNAR in place. Apparently, the patient had an unwitnessed fall with some evidence of head injury. The patient is asymptomatic, otherwise, they are at their baseline. And this person is on a DOAC. As per NICE guidance on head injury, for people who are above 74, they are seldom offered neurosurgical intervention because the risks outweigh the benefit. Okay. Should we even be scanning these age groups?
That is a very good point. So let's say for the same scenario, we do a scan on this patient and we find a bleed. And then we call the neurosurgeons, may not accept it. Most commonly, given the frailty, the other comorbidities and everything, and they refuse any further neurosurgical intervention. So now what are we going to do is the question.
Exactly.
So what is the point of scanning in the first place?
Yeah.
Is what you're placing it here, which is a very good question. But I would say we can still do a little more for the patient. So for one, that scan can help us with the prognosis of the patient. So we can update the patient if they have the capacity, or we can update the next of kin and the family. It gives us a bit of a bigger picture of what is happening with that patient. And second, we can stop the DOAC, or we can reverse the anticoagulant, and there's a few more we can offer for this patient in the periphery, even though they're going to end up with us in the district hospital with a local admission and nothing further going to be done. But still, there's a little more there to offer for the patient when we do the scan and we find something in it. So said that, I would say maybe that is a little enough. What do you think?
I think that makes sense. Just to add to what you've said about someone being on DOAC, the decision to whether we need to stop or stop the medication, we need to look at the reason as to why the person is on the DOAC or antiplatelet in the first place, and go with benefit versus risk. Sometimes we might need to go as far as to discuss with the cardiologist, for instance, or the stroke specialist, the person who was who made the decision to put them on the agent. and make a shared decision. So I think that's something to consider.
Exactly. So there is a little more we can offer for the patient by getting that scan done. Of course, not to go out of the algorithm and just scan everyone, but when it warrants for it, even though we know there might not come much out of it, even if it is a positive scan, I feel like that scan can give us a little more answer for the patient and also a little more help we can provide for them, that is a short of any kind of a neurosurgical intervention.
Fair enough. I've got a question for you.
Hmm.
Let's say there's a child who's under 16 presenting with neck pain after trauma, and it's an isolated injury without head injury. In general, we do hesitate when it comes to isolated neck injury, whether to get them through a CT scan because of risk of radiation. Is there any role for obtaining 3-view cervical x-rays so that we can avoid the possibility of doing a CT scan?
There is.
Okay.
So, nice guidance have a beautiful algorithm for less than 16 with suspected cervical spine injuries. So, if we go by the algorithm, if we suspect, for example, if the child has a pain or tenderness in the cervical spine, and then you go down the algorithm, there is some kind of a dangerous mechanism involved in this, right? Or the child has some kind of a predisposing high risk factors for neck injuries, such as a collagen disorder or a bone disease, or axial spondyloarthritis, which are high risk. And you have any of them, yes, you can actually get a 3-view cervical spine X-ray as per the NICE guideline. We are not jumping to the CT. We can go through an X-ray, and provided it's an adequate film, because if it's inadequate, then the child will end up in a CT. But if it is adequate film, X-rays have a role. But that is not the only criteria. There are a few more are there, but I would highly recommend you guys going through that algorithm. It's actually the algorithm number 4 in the as per the NICE guidelines, and you can go through and see there's few more criteria that you can use to obtain a cervical spine X-ray on a child rather than a CT.
Nice.
All right, Ranjit, one last question.
Mm-hmm.
So, the dangerous mechanism for an adult in sustaining an injury is falling from more than 1 meter or 5 steps. All right. So, if we think that in perspective of an elderly patient, of course it is significant. But for people like you and me, that doesn't sound very dangerous. But the guidelines doesn't give an age cutoff for this dangerous mechanism. It's for everyone, every adult. So what am I missing here?
So that's a very good question. When we consider fall from standing height, evidence clearly shows that in the older patients, merely falling from standing height is classed as a dangerous mechanism, can be quite devastating.
True.
But in general, when we look at falling from a height of more than a meter or 5 steps or 5 stairs, that can also be quite dangerous, and it depends all on the force that acts on the skull or the brain. Let me explain. So when looking at the physics involved, with regards to a fall, there are 2 main things to consider. One is velocity of the impact. Second, it's force of impact. When working around the math and everything involved, let's say for example, there's a 70 kg person who is 6 feet tall. This person's head weighs an average of 5 kilograms, and they have a fall from standing height. Let's say that the first point that makes contact with the ground is the head. After crunching in all the numbers, we find out that the velocity of impact roughly comes to 6 meters per second. And with this, we can calculate the force of impact, which, depending on the nature of the surface, if it's a hard surface like concrete, the force can be as high as 6,000 newtons, which translates to 600 kilograms of force. That's a lot. But it's not that simple. Okay, oftentimes people just don't fall straight forward. There's always some kind of pivoting motion involved. They kind of twist, they turn. The first point that makes contact with the ground might actually be a part of the torso, the hip joint, the shoulder joint, before the head hits the ground. So interestingly, there was a study done by some researchers that looked at anthropomorphic test dummies, and they had them drop from standing height at various positions, and they measured the impact on the head. What they found out was that the impact generated was actually much higher, and it ranged from 400 kilograms to up to 2 tons.
Wow.
That acts on the head from just merely falling from standing height. And
Sorry.
bless
Excuse
you.
me. Thank you.
Okay, so
By the way, it's a very fancy way of saying they were pushing mannequins down.
yeah. And as a fact, okay, all it takes to actually fracture a skull is a force from 250 to 350 kilograms, and that's enough to cause the skull to fracture. So yes, to answer your question, a dangerous mechanism can be standing height. It can also be a height of more than a meter or 5 stairs in someone who's like young, like you and me.
Perfect. That is scary.
Yep.